Hello, good evening, one and all. Welcome to this Tuesday Takes 5 on the respiratory diseases in pediatrics is our today's topic on which the six presenters will be presenting. So, I would like to welcome all of you to this platform. For the next 1 hour, we will be hearing our esteemed speakers with the comments from the judges and also from our super judge, moderator, and guide mentor, Dr. N.K. Subramaniam. Globally, acute respiratory tract infections are the leading cause of mortality and morbidity in children below 5 years. An estimated 1.9 million childhood ARTI deaths are reported from developing countries, of which 20% occur in India. In India, around 14% infant deaths and 16% of death in under 5s are caused by ARTIs. So this is a very great problem. The factors in India especially are related to the high mortality and morbidity are the poverty, overcrowding, poor nutrition, poor air quality, misuse of antibiotics. And also these factors contribute to the increased risk of acute manifestations becoming chronic, and the lung functions persistently deteriorates over a period of time, thereby leading to chronic respiratory diseases in adulthood. So, dear all, the respiratory disease diagnosis is based on a comprehensive clinical history and a complete physical examination, as we know all. Primarily, the focus should be on the chief complaints that is pertinent to the clinical situation, but must include the past medical history, social history, family history, and review of systems. All information gathered together has to be obtained in a logical and complete sequencing. But for this, a good communication between the doctor and the parents of the child has to be needed, and also a complete respiratory and physical examination also. So today we are going to go through various topics in this series, of which I would first like to welcome our own president, Dr. Gangolia sir, who is President Maha AP, to please share some blessings.
Thank you, madam. Good evening and namaste, respected dignitaries, our mentor of today's session, Dr. Subbu sir, excellent judges, Dr. Shishir Modak sir, Dr. Prakash Vaidya sir, and great six speakers, presenters, as well as moderators, Dr. Renu madam, Dr. Sushma, Dr. Sonali madam, office bearers of and EBs of Maha AP, my secretary, Dr. Amol, as well as in absentia, Dr. Jay, Dr. Vinayak, and Maha AP Women Committee led by our dynamic chairman, Dr. Renu madam, as well as co-chairman, Dr. Sonali madam, and attendees on this dais, as well as attendees on Maha AP YouTube channel. Hearty congratulations to Maha AP Women Committee led by chairman, Dr. Renu madam and co-chairman Sonali to organize this Tuesday episodes. And this today is the 5th episode, and they are organizing successfully, running the super fast expresses on every third Tuesday at 9 p.m. and loaded with the knowledge which delivers the gist of knowledge only in 5 minutes of which will be very useful to the general pediatricians. We are very fortunate. I do not know whether Dr. Subbu sir is there, but we are very fortunate to have Subbu sir. Dr. Subbu sir. Yes, welcome, Dr. Subbu sir. Subbu sir today as a mentor, as this concept of Mudde Ki Baat in 4 minutes was a brainchild of his only, and still I distinctly remember that T20 episodes of 20 topics, 20 speakers, 4 minutes each in Mahapedicon 2019 Amravati. And I remember Dr. Subbu sir being acting as a Sri Krishna, leading the chariot of the knowledge, making all 20 speakers to ride the chariot of knowledge for 4 minutes each and getting all the knowledge from there. And I was fortunate to be one among of them. I'm very sure that this session will be very useful, and rains are started. Respiratory disease will be on rise, and let us see how this superfast expresses enlightens our destination, which are the brains, to deal this season the respiratory disease very effective manner. And I'm sure this all guests, 6 presenters will be doing fantastic job. All the best to them, and wish each one and everyone happy learning, and let us enrich our knowledge. Thank you very much.
Yeah, thank you so much for your kind words, sir. Now I welcome Professor Subramaniam, sir, on this dais platform. And sir is today's mentor, guest of honor, our godfather and whatnot. There are no words for him. Sir is presently the Vice President of CIAP South Zone. And also he is the chairperson of the respiratory chapter 21-22. Sir, we need your words of wisdom and blessings for this program for 1 to 2 minutes.
Okay, you are giving me 1 to 2 minutes, but very less time for the participants. Dr. Hemant Bhaiya, Dr. Renu, and my dear Amol, who is the Anmol Hire for Maha IAP, and many more in the crowd. When Amol called me with this concept, I was very happy, and he was asking me. Then I had no other names to suggest other than my mentors, who are now today's judges, Dr. Prakash Vaidya and Shishir Modak. Many of you do not know. I am just a young boy with them who learned a lot from both forever in respiratory chapter, because they have been with me. I do not know, undefeated soldiers in Mahabharat, whatever you want to take it up. Now, regarding Maha IAP, it is Mera IAP rather than Maha IAP, as far as I am personally considered. Being born and brought up, and also got my knowledge of pediatrics from the very land of Maharashtra, I will not leave any stone unturned for whatever little invitation or even otherwise bulao. I will be just there for any session where I'm emotionally linked. My salutes to my teacher, Dr. Anand Pandit from KM, as well as Dr. Mridula Phadke in those times, and also to Professor Dr. Y.K. Amdekar, who was my examiner. So I have a lot of nostalgias from Maharashtra. But let me tell you, this session is going to be mouth-watering, and you will enjoy. I have spoken to every one of them. They are all rejuvenated, and they are in the fighting spirit. And let's listen to them. And my hearty congratulations to the judges of today, Dr. Shishir and Dr. Prakash Vaidya, as well as the honorary and dignitaries who have assembled over here, and wonderful viewers with whom I cherish. Let's enjoy the best of the science in very short period of time. Maybe these sessions will become as popular as IPL, and there could be some auctions in future as well. So with these words, I will hand it over back to Renu. You can take over from here.
Okay, sir. Thank you so much for such a lovely words. So today's judges, there are two. First, I would like to introduce Dr. Shishir Modak, sir. He's MD DCH. He's a panel consultant at Dinanath Mangeshkar Hospital, Pune, National Convener 21-22 Asthma Training Module, National Convener Under 5 Visas Module, Master Trainer in RTI, JAM, RAP, PSPID, and Nutrition modules. He was the organizing chairperson Respicon 2011 and past president of IAP Pune branch. Welcome, sir. The next our judge is Dr. Prakash Vaidya, sir. Prakash Vaidya, sir, is MD DCH. His diploma in pediatric sleep medicine from University of Colorado. He is presently attached at Fortis Hospital, Mumbai, and Child Health Clinic, Mumbai. He is a senior pediatrician with special interest in pediatric pulmonology. He joined National Convener Asthma Training Module 21-22 Revision Chapter, co-convener and writing committee member of Under 5 Visas Module of IAP, as well as writing antimicrobial responsibility. He is a national trainer for IAP, NTEP, TB module, NRC cuff module, etc. He was the past president of IAP Thane branch, and he has 4 index publications and 1 textbook chapter to his name. Welcome to you, both of you, sir, for this honor you are given to us for chairing these judges. So we will go right over to our next directly to the talks. So the sequence will be followed by 6 speakers in a row, of which the first 3 speakers will be judged by Dr. Shishir Modak, sir, and the next 3 speakers will be judged by Dr. Prakash Vaidya, sir. So the first in line is upper respiratory disorders. She is none other than Dr. Mangai madam, so gorgeous looking ma'am in pink sari and also very confident. She's pediatric consultant at Navi Mumbai, and yes, she's pursuing in fellowship in allergy and immunology. Hats off to you, ma'am. So welcome to you for your speech. Please share your screen.
Thank you, ma'am, for such kind introduction. And good evening, everyone. I'll just start sharing my screen.
Sure. Yeah, meanwhile, those who have joined, please put your name, MMC number and IAP number in the chat box. Yeah, ma'am, you can start.
So good evening, everyone. I have been given 5 minutes for my talk on upper respiratory disorders. So before I start my talk, I would like to emphasize that in this 5 minutes, I would speak more on and stress more on the key messages rather than repeat all the respiratory disorders that we are already aware of. So the upper respiratory tract extends from the nasal cavity up to the level of cords in the larynx and acts as a conducting system for air. So any upper respiratory disorder would either be infections of the nose, the nasal cavity, the nasal passages, the sinuses, pharynx, or anything that would interfere with the function, that is the conducting air. So any obstruction. It could be congenital, like the choanal atrasias, or it could also be foreign body. Then there is another group of disorders that could be included, which is others, where we would include allergic rhinitis, which is a common cause of upper respiratory symptoms, and or even tumors, though rare. So, like I said, I would like to talk of infections, obstruction, and a third group, others. Coming to infections, and especially infections of the tonsils and pharynx, which is the bread and butter of all pediatricians. More so now, from the last few weeks, we all are seeing such a clinical picture in our OPDs. As against this. So, yes, rightfully, the first one is viral tonsillopharyngitis, and the next picture is a bacterial tonsillopharyngitis. So do we really have to examine the throat to come to know the difference? No. We can know the difference between a viral and bacterial by a complete detailed history, the onset, duration, and progress of each symptom, the age of the child, how the child is on examination, whether it is febrile, whether the child is playful, and then an examination will show such a picture. So quickly knowing the treatment of viral tonsillopharyngitis is purely symptomatic, whereas in bacterial tonsillopharyngitis, we need to start the child on appropriate antibiotics, which we all do. But what is important to remember is that the duration of treatment should be for 10 days, except azithromycin, which in some cases we give, in some special cases, that duration is of 5 days. Children come to us with repeated episodes of pharyngitis, and not all of them need to be subjected to tonsillectomy. We need to understand that there are very specific guidelines for tonsillectomy, and only a very few children need to go for that. So what are the key messages? The key messages is generally, if we have a history which is a little acute, we are looking more into the infectious origin. Viral is more common than bacterial. In fact, viral pharyngitis is around 80% of our OPD, whereas bacterial forms a very small proportion. A good history, like I said, will differentiate. Absence of symptoms will also help us. It's not only presence, absence, like absence of cough and cold will point more towards bacterial. If in any point of time we are in a dilemma, and we don't need to start antibiotics. We can wait and ask the child to come for follow-up within 24 to 48 hours and then decide on next line of therapy. Since in viral, it's only going to be symptomatic treatment, counseling with good time is very essential. If we tell the parents what to expect, then they will have more patience and stay with us rather than do doctor shopping on the 3rd or 4th day. I've already spoken about appropriate antibiotic and correct duration. Coming to adenoidal hypertrophy. Now, complaints of these complaints are generally persistent. So the child will come with persistent mouth breathing, persistent nasal obstruction, repeated ear infections, may even, in severe cases, may even come with obstructive sleep apnea. When this child comes to you in the OPD and the mother is narrating the history, we can just look at the child and look for typical faces. That is examination of the child and observing the child for looking at the faces and even some allergic mannerism, which can give a clue to diagnosis. Sinusitis also points to persistent nasal block. But examination of the nasal cavity with mucopurulent discharge in a child with high fever or a sick child will tell us. Sinusitis, though simple to talk, but diagnosing is different because of its varying presentation and varying duration of symptoms. But here, the main key of treatment is pain relief, treatment of nasal obstructions. Here, I would want to emphasize that use saline drops for relieving nasal obstruction. Please do not use decongestants and antihistaminics. Antibiotics need to be given for 10 to 12 days, not 4 or 5 days, 10 to 12 days or 1 week beyond symptom resolution. Investigations is not really needed and we need to watch for complications. So what are the key messages here? If there are persistent symptoms, it's less likely infections, more likely obstruction in these disorders, upper respiratory disorders. Observe the child who will give us and completely examine the child, including the ears. Any persistent obstruction of the adenoid and all will lead to otitis media. Otitis media, what I want to stress here is an entire spectrum. So though we can easily diagnose acute otitis media in our OPD practice, we often miss out on the silent otitis media and otitis media with effusion. A simple otoscopic examination of the ear drum will give us our diagnosis. And if these kids are treated appropriately, with the appropriate treatment. Antibiotics need not be started in all cases. Antibiotics are needed only in younger age groups and in severe disease. We will save a lot of children from hearing loss and other complications. So key messages, always examine the ear, not with a torch, with an otoscope. Treatment depends on the age, severity of symptoms. Coming to two diseases which present as upper airway obstruction, that is croup and acute epiglottitis. Now, how do we diagnose? What is it? Here again, observing the child. Both of them can present as acute emergency, acute airway obstruction. But just observing the child and hearing the bark-like or the brazy cough that the child has, the inspiratory nature of the stridor will clinch the diagnosis towards croup. Whereas in acute epiglottitis, we'll typically see a child who is sitting in that tripod position with a little extended neck with drooling saliva, trying to maintain the airway. So what are the key messages? Observe the nature of the sound, the nature of the stridor, all of the position that the child is comfortable in, all of that will give us important clues, and investigations are not always needed. Diphtheria and pertussis, thanks to effective immunization, we really don't see in practice. Just lastly, coming on to the other upper respiratory disorders, again, examination of the newborn. When we are attending a delivery, we really need to check on choanal atresia. Bilateral, very easily diagnosed, but unilateral, often missed. Laryngomalacia, we need to tell the parents that it is a noisy, it is present in infants and they will eventually grow out. Cleft palate and laryngeal valves also need to be kept in mind. Also, foreign bodies, a very, very important thing. Sometimes the history will also not be available. So we have to look for it. Allergic rhinitis, if not treated well, it will lead to more complications and persistence of symptoms. Nasal polyps also needs to be looked for. Tumors, parapharyngeal abscess and malignancies, though not very common, also need to be kept in mind while dealing with upper respiratory disorders. I think with the key message of good history, good examination, including ear examination, the nasal cavity examination, the throat examination in every child, and patiently counseling the parents will help us in dealing with upper respiratory disorders. Thank you.
Yeah, thank you so much, Dr. Mangai ma'am, for your excellent lucid presentation. I will now request Dr. Shishir Modak sir, so to please take on your speaker.
Yeah.
Yeah.
Congratulations, Dr. Mangai. You have done a good job. And in such a short time, you have covered upper respiratory tract disorders very nicely and given right messages. Actually, it should be more of upper respiratory infections, because in 5 minutes to cover both infectious and non-infectious is really difficult. But you have done really good job. And the message that tonsillopharyngitis particularly, or most of the upper respiratory, mainly viral, and antibiotic is not required, and only symptomatic treatment is all that necessary. Otitis media, you rightly said that otoscopic examination is very important, and even sinusitis, how to diagnose. Just in nutshell, you have given the correct messages. So congratulations to you.
Thank you, sir.
Yeah, thank you so much, sir, for your excellent comments. And thank you, Dr. Mangai, ma'am, for your topic. Now we will move on to the second topic, which is recurrent respiratory symptoms by Dr. Preeti Joshi. She is pediatric consultant and diet counselor, director, Happy Kids Hospital, Jalgaon. Over to you, ma'am. Can you share your presentation? Yes.
Good evening, everyone. Today, I'm going to discuss with you all a very common topic of our office practice, that is recurrent respiratory symptoms in children. When we are dealing with recurrent respiratory symptoms in children, we need to ask ourselves or to the patient 3 common questions. Which respiratory symptoms commonly recur? At what age are they common? And when do we say that they are recurrent? And why we should be worried about them? Yes, because they can be a sign of underlying medical condition ranging from congenital abnormalities of lungs to a dreadful primary immunodeficiency syndrome. When do we say the symptoms are recurrent? Symptoms occurring at least 2 weeks apart with a period of no symptoms in between is said to be recurrent symptoms. In upper respiratory tract infections, as previous speakers have said nicely, that tonsillopharyngitis, actually, there is no cutoff for the upper respiratory tract infections to be said as a recurrent. But for tonsillopharyngitis, 3 to 8, I have written it as 5 because many references show 5, but 3 to 8 episodes per year are said to be recurrent tonsillopharyngitis. But in tonsillopharyngitis, not only the frequency is important, but the severity of symptoms and the sleep apnea which the child faces can also give a clue that he needs to be operated for tonsillitis. In otitis media, 8 or more episodes are said to be recurrent when they occur in a period of 1 year. In sinus infections, 2 or more episodes are said to be recurrent. In lower respiratory tract infections, 2 episodes of clinical features with documented radiological pneumonia with a clearance in between over 1 year, or 3 such episodes of pneumonias in any given time frame is said to be a recurrent pneumonia. Persistent pneumonia is said when unremitting symptoms with persistent radiological abnormalities are seen over a month in a coughing child. What are recurrent respiratory symptoms? When a cough is there, which can be of acute onset or chronic, snoring and other nasal symptoms like rhinorrhea, noisy breathing, breathlessness and wheezing, throat pain, or child may complain of earache and ear discharge. These are commonly seen in 3 to 8 years of age group, that is mostly seen in preschool and school-going age children. And what are the common causes of recurrent upper respiratory tract infections? Recurrent tonsillopharyngitis is mostly, we all know that it is viral of origin, but sometimes it can be bacterial. A recurrent sinusitis, there are many local causes like a deviated nasal septum or nasal polyps also add to the infection. There can be cystic fibrosis or primary immunodeficiency disorders. A recurrent otitis media with or without effusion, there can be adenoidal hypertrophy, primary immunodeficiency disorder, or there can be severe dyskinesia. In case of recurrent respiratory symptoms, we have 4 categories of children. The first category, the child is absolutely normal, with simple viral URI, and we don't have to do much about this child. There can be some children with atopic incidences. They are atopic children. A third category is that the patient has multi-system concurrent disease like he may have some congenital heart disease or a valvular heart disease, cystic fibrosis, and so on. Then there is one category where the child is having immunodeficiency. What are the factors associated with recurrent respiratory symptoms? Exposures are very important. A child going to daycare centers for a longer time, a child with siblings going to schools and carrying infections to home, children living in small crowded homes or homes with high humidity and dampness. As we all are aware that breastfeeding is very important because it gives you lots of antibodies protection and those protect for respiratory and gastrointestinal infections. So the child who is not being breastfed properly or inadequately can be a victim to this recurrent respiratory symptom. Certain pollutants like smoke or mothers who smoke during pregnancy, their children can have this recurrent respiratory symptoms. Pets, as we all are aware that dogs and cats with their small tiny hairs lying down here and there in the houses, they can also cause recurrent respiratory symptoms. History of gastroesophageal reflux, premature births, low birth weights, bottle feds in prone position, faulty feedings can also add up to this condition. Certain anatomic factors like bronchial hypoplasia, bronchial stenosis, tracheomalacia, nasal polyps, deviated nasal septum, craniofacial abnormalities, and foreign bodies in airways are also certain anatomic factors contributing. Post-nasal drips, eustachian tube malfunctions, asthmas, allergies are also there. Secondary immunodeficiencies caused by various factors add up to the recurrent respiratory infections. Then, what are the red flags? Or each and every child needs to be investigated? The answer is you have to look for this. We have to monitor the growth and development of the child. If the child is not growing well or is not gaining the weight, then definitely think for certain other disorders which are not only associated with respiratory problems. Then there can be marked chronic upper airway symptoms like snoring, rhinitis, sinusitis, and the child may be disturbed all throughout the day. So we need to investigate. Symptoms right from the first day of neonatal life, yes, those are very serious. They can be GRD, they can be tracheoesophageal fistulas. So we need to have a look at it. Severe symptoms with unusual pathogens can also tell you that the child may have immunodeficiency syndrome. Chronic productive cough with thick mucus for more than 4 weeks can lead to severe dyskinesia or cystic fibrosis. The feeding issues, yes, they'll definitely tell you that these are not simple symptoms. We need to investigate. And the persistent unremitting symptoms or worsening of the symptoms should also be investigated. There must be rather a stepwise approach in case of recurrent respiratory symptoms. In step 1, we have to look whether it is only related to upper respiratory tract or both or lower respiratory tract symptoms. Secondly, as we discussed earlier, it is assess the growth pattern of the child, whether he is gaining proper weight or not. Look for extrapulmonary features, whether the child is having thick mucoid sputums and all. Look for severity of infections and unusual organisms, and assessment about treatment is needed, and response of the child given to the treatment is also to be assessed. For example, if you consider that the child is having asthma and we start him on corticosteroids and there is a miraculous response to the treatment, then we can say that he is responding well to our asthma. Investigations in case of recurrent respiratory tract infection, yes, a thorough ENT examination along with a simple CBC can lead to many clues. A good quality X-ray and a good reading of X-rays can always solve our problems. But when we have some certain suspicions in X-rays, we can judiciously use CT scan or MRI. When we suspect foreign body, we should go for bronchoscopy. Nasal endoscopy for polyps we have to do. Children showing atopic reactions should be allergy tested. Then sweat chloride test, ciliary function test, and serum immunoglobulin levels in immunodeficiency symptoms. Treatment in these cases depends upon solely on the underlying cause, because whatever is the cause, upper respiratory tract infection need to be counseled and thoroughly examined, because those are mostly viral origin and they can be taken care of easily. Up-to-date immunizations to prevent primary and secondary infections is our key in office practice. We should use the antibiotics judiciously And in case of immunodeficiency syndrome, we should give high immunoglobulins. It's a culprit. What is our conclusion? Multiple upper respiratory tract infections in infancy and childhood is such a common problem. No treatment is required in most of the cases, but we should be very cautious for their recurrence. Red flags, as discussed earlier, have to be monitored. If no red flag is found, only monitor growth and development and keep an eye on the development of new symptoms. A careful history and detailed examination is of utmost importance.
Yeah, thank you, Dr. Preeti Joshi, madam. Now I invite Dr. Modak sir for his expert's comment.
Dr. Preeti, your presentation was very good and very precise. And again, you have also done it very nicely. As you have said, I'll just like to reiterate few points that what is recurrent and what is persistent is very important. As good that you have given a definition of what is recurrent and what is persistent, because for example, in asthma, we say that it is a recurrent symptoms, not persistent. If it is persistent symptoms, then it is unlikely to be asthma, right? So for a clinician, it is very important to find out from history that whether it is really recurrent or persistent. Sometimes what happens is the symptoms are persistent, but because child is treated haphazardly or inadequately, and he goes from doctor to doctor, it appears to be recurrent. So that you have to differentiate clinically with the help of history and examination. And secondly, as you have said, that red flag signs or what is serious, because many times these repeated or recurrent respiratory disorders, upper respiratory disorders, are benign in nature. But you have to find out that which of them are serious, and we should not miss any serious disorder. And timely action in such cases, for example, congenital malformations, etc., are very, very important and maybe life-saving. So differentiating between a benign disorder and serious disorder is very important. And diagnostically also, investigation-wise, you have enlisted them properly, that whatever investigations are easier and can be done routinely, they should be taken first. And then you can go for bronchoscopy, CT, MRI, depending on the need of the hour. Okay, so you have put it very nicely, and I congratulate you for the same. Thank you.
Thank you, sir. Can you stop sharing, madam? Preeti, madam?
Yes.
So now we move over to the next talk. It is the aerosol delivery therapy, and it is by Dr. Sunil Seth. He is a pediatric consultant and neonatologist from Mahad, Raigad. Over to you, doctor.
Thank you, ma'am, for kind words. Good evening, everybody. Today, we are going to discuss aerosol delivery therapy. Aerosol is a suspension of very fine liquid or solid particles in a gas. Aerosolized medications and its delivery is an important component of treatment of various respiratory disorders and is critical in management of asthma in children. There are several advantages of delivering the drug by aerosol rather than giving IV medications or oral medications. First of all is there's a deposition of the drug at the site. So there is a less dose is required to achieve the therapeutic effect. Faster onset of action as compared to the intravenous or oral medications. We get a bronchodilator effect after nebulization or even for inhaler therapy quite easily. And there are less side effect as there is a decreased systemic absorption of the drug. Various diseases which are treated or where the inhalation therapy is used is obstructive airway disease, including asthma, congenital emphysema, bronchiectasis, infections such as RSV and bronchiolitis. Acute upper airway obstruction, usually croup or post-extubation in upper airway, post-extubation upper airway edema, chronic lung diseases, including bronchopulmonary dysplasia and cystic fibrosis. There are 3 types of aerosol delivery devices: nebulizer, which can be jet flow nebulizer, ultrasonic, or vibrating membrane nebulizer; pressurized metered dose inhaler, and a dry powder inhaler. Whenever we are going to select a device, we have to keep in the mind the age of the patient, what is the drug deposition of the different devices, and whether we are going to use this device for acute episode or long-term management or a controller use. If any child having the age 3 years or less, or anyone who cannot breathe consciously through the mouthpiece of the spacer, we have to use MDI with the spacer and a mask. Any child more than 3 years, MDI and spacer is suitable. However, for 6-year-old male child can take a MDI, but spacer is ideal. Spacer can be used and they can use dry powder inhaler as well. But MDI plus spacer is the most versatile device. Then what are the factors affecting the aerosol deposition? First is the property of the device. 6 to 60% of the total dose of medicine can be delivered to the peripheral airways when the device is optimally used. Then second is the aerosol particle size. If the particle size is less than 0.8 micrometer, it will be exhaled in the air. If the particle size is between 0.8 to 2 micrometer, there will be optimal alveolar deposition. Whereas particle size 2 to 5 micrometers, there will be lower airway deposition. And if the particle size is more than 5 micrometer, there will be oropharyngeal deposition. And it depends upon the properties of the medication to be delivered. If you compare MDI with the nebulizer, the deposition of the drug in the airway with the MDI is 10 to 15%, which is far more than nebulizer, which is hardly 1 to 5%. And oropharyngeal deposition of the MDI with the spacer is less than 10% as compared to nebulizer, which is 50% or more. So MDI with the spacer or plain MDI with the spacer and the mask overscores over nebulizer. If we are managing an acute episode, if it is a home treatment to be given, we have to use MDI with the spacer or dry powder inhaler can be tried. But if in the hospital, MDI with the spacer and a mask and nebulizer to be used only in severe episodes. Do not use dry powder inhaler in moderate or severe exacerbation of the asthma. If you are using it for the controller use, for control regime, especially if the patient is requiring moderate to high dose of inhaled corticosteroids, we use MDI with the spacer instead of DPI even in the older children. We have to use any spacer, but use a spacer because it eliminates the need of hand-breath coordination, reduces local side effect of inhaled corticosteroids, improve drug delivery. It dilutes the taste of inhaled sprays and eliminate cold freon effect. If we compare mid-dose inhaler, the dry powder inhaler with the nebulizers, performance-wise, MDI overperforms over DPI as well as nebulizer in all the aspects. Measured if the aerosol particle size is less than 5 micrometer, there's high pulmonary deposition, low mouth deposition, reliability of the dose, not compromised by humidity, physical and chemical stability is there, and low risk of contamination. Convenience, MDI is always more convenient than DPI and nebulizer. And why nebulizer should not be the first option? Because it requires electricity, it is noisy, it is irritable to the children. It requires regular cleaning, which can be a lengthy procedure, and there could be cross infection. It may result in a side effect because the high dose is being delivered, and it should not be used it should be used only in a patient with severe exacerbation. What is the role of nebulization? It should be used in a patient who is a critical unconscious. If the patient required high doses of bronchodilators and steroids to be given along with the oxygen, patient do not respond to the regular treatment or unable to coordinate with the inhaled devices like MDI and DPI. To have a proper optimal aerosol deposition, the technique is most important. We have to follow the technique properly. Whenever we are going to use the inhaler for the first time, we have to prime the MDI, or if it is MDI we are using after a long time, we have to prime the MDI. Shake the canister vigorously for at least 5 seconds before using it. Put the mouthpiece between your teeth and close your lips tightly around the mouthpiece of the spacer. And if you are using the mask, completely cover nose and mouth. And whenever we are breathing it, we have to breathe in and out slowly. We should not do it rapidly. It should be slowly. Breathe in slowly, exhale slowly. So 5 to 6 breaths are sufficient to completely empty the chamber. And if you need to give more than one puff, at least wait for 30 seconds in between the puffs. Do not load both the puffs into the chamber at the same time, or do not use 2 to 3 puffs at a time. One puff has to be used at one time only. So we have to use MDI with the spacer and with the proper technique to achieve the maximum aerosol deposition. Thank you.
Thank you so much, Dr. Said, for your presentation on aerosol delivery therapy. Now I would request Dr. Modak sir to have his comments on this topic.
Yeah. Dr. Sunil, you have done a good job by covering all the points very nicely and in 5 minutes. One or two points I would like to mention. That one thing is, one of your slides, you have mentioned that 6 to 60% of delivery to the periphery. So no aerosol device gives 60% delivery to the peripheral part of the lung. It is hardly maximum 20-25%, not more than that. Okay, so that needs to be corrected. Even with MDI and spacer, the deposition is on the spacer wall. 40 to 50% is on the spacer wall. That's why side effects are less, but that doesn't reach to the lungs. To the lungs, only 15 to 20% goes in, and other part is deposited on the spacer wall, but that reduces the side effects. Secondly, you have said priming of MDI. It is not the priming of MDI, it is priming of the spacer. Whenever you use the new spacer, so that also you change. It is not prime the MDI, prime the spacer. Okay, so when you use new spacer, you need to prime it by putting 2, 3, or 4 to 5 puffs in the spacer, and that's why static charge on the wall of the spacer is reduced. So change that from priming of MDI to priming of spacer. Yeah.
Okay, thanks.
So otherwise it was good, and you have covered all the points. You have talked about the technique very nicely. And nebulizer should be condemned, particularly home nebulization. All the practicing pediatricians know that nowadays patients and their parents buy nebulizer at home, and every now and then they give nebulizer at home or just for common cold also, which is very wrong. So that's why it should be discouraged, and there are many side effects, and it is the most inferior option of delivery of the aerosol therapy. So nebulizer should not be encouraged at any cost. Okay, so that's all from my side. Thank you.
Yeah, thank you so much, sir, for your expert tips and also for judging these three our speakers. Thank you so much. Dr. Subramaniam sir has put in the chat box that he has his videos on how to use spacer and nebulizer. You can Google on YouTube NK Subramaniam sir. Okay. So there are excellent videos. I have seen it. Now, the next part, I would like to welcome our MMC observer of today's, Dr. Rajendra Kulkarni, sir, who is senior pediatrician from Nashik. Sir, can you please unmute yourself and also start your video, and please give us your blessings. Dr. Rajendra Kulkarni, sir. Pallavi madam, is he there?
No, ma'am, I cannot see him in the participants.
Initially, I was seeing him. Okay. We'll move on to the next three speakers. So for this, the judge is Dr. Prakash Vaidya, sir. The next in line is Dr. Ashwin Kathar, who is pediatric intensivist from Om Bal Rugnalaya, Jalna. His topic is pediatric respiratory emergencies. Over to you, Dr. Kathar.
Thank you, ma'am.
Yeah, we are seeing your slides, sir. You can start.
Ma'am, he is not there.
No, I'm telling to Dr. Kathar.
Good evening, all. Today we are going to discuss pediatric respiratory emergencies. Among the pediatric emergencies, respiratory emergency is one of the cause. As we know, kids are not treated adults, so respiratory infection is common in pediatric age group as compared to adults. Kids are having large heads, small mandible, large posterior place tongues, high glottic opening, presence of tonsil and adenoid and small airways. All these factors will cause obstructive disease more common in pediatric age group as compared to adults. Poor access in muscle development, less rigid thoracic cage, primary diaphragmatic breathers, increased metabolic rate and more O2 demand. All these factors will cause decreased respiratory reserve. So with increased O2 demand, chances of respiratory failure is high. And as we know, respiratory failure progresses to respiratory arrest. And child becomes hypoxic more quickly as compared to adults. So most common respiratory emergencies are croup, epiglottitis, bronchiolitis, bronchial asthma, foreign body, and pneumonia. Just to highlight, croup, it's a viral infection, age 3 to 6 years, parainfluenza, or other viruses. Presentation, it may be mild or severe. If the severe is the presentation, patient may present with severe retractions, stridor at rest, diminished air entry and agitations. Diagnosis, clinically, you will get a stridor, or X-ray, you will get a stipple sign, where you will get a subglottic stenosis with a normal tracheal counter. Treatment, all treatment in the form of ABC, mainly humidified oxygen, nebulization with epinephrine, and if it doesn't respond, we can give a single dose of dexamethasone. Second, it is epiglottitis. It is a bacterial infection, H. influenzae. Recently, we'll get less cases due to widespread vaccination. Age common is more than 4 years. It is presentation is a high-grade fever, severe respiratory distress, difficulty in swallowing, stridor, change in voice, and 1/3 of patient may present in shock. Again, diagnosis is clinical. If you are getting respiratory distress with sore throat, with drooling, suspect epiglottitis. X-ray, if you take a lateral X-ray, you will get a thumbprint sign that is thickening at the level of epiglottitis. The most important thing, treatment is in the again same form, that is we have to give humidified oxygen, antibiotic as it is a bacterial infection. And most important thing is we should not go for any manipulation. Even though baby is not accepting oxygen, we can give oxygen by blowing rather than forcing him to take the oxygen. And we should be prepared for respiratory arrest on assisted ventilation and CPR when needed. Third is bronchiolitis, very common, age less than 2 years, any season, viral infection, that is respiratory syncytial viral or other viruses. Presentation is in the form of cough, wheeze, fever, poor feeding, apnea, and cyanosis, and they can progress to severe respiratory distress. Diagnosis is by X-ray, where you will get hyperinflation. Treatment is again same, that is we have to give oxygen, maintain the hydration, maintain the airway by proper suctioning. Usually, there is no role of bronchodilator and epinephrine, and we should anticipate and need to intubate. You can see by decreasing the size of the bronchioles, resistance will increase many folds. Now, next is bronchial asthma. It is age commonest is more than 4 years, and it is we know it is a lower way hypersensitivity to allergen, infection, cold, or exercise. Bronchospasm, edema, and mucus production is the pathophysiology of bronchial asthma. In severe form, this patient may present with severe tachypnea, nasal flaring, use of external muscles of respiration, chest retractions, sometimes paradoxical breathing, and if hypoxia persists, they may land up with agitation, drowsy, confusion, and cyanosis. On examination, if you are getting a silent chest, it is a danger sign. Any patient of routine asthma, if not responding to a routine management of beta-2 agonist inhalation, and if symptom persist, we can label that as a status asthmaticus. Again, diagnosis is clinical, or you can go for pulmonary function test. Management is same. You have to give oxygen, proper position, maintenance of hydration. Initially, we try with beta-2 agonist or anticholinergic drug nebulization. If they doesn't respond, we have to shift to steroid, or if not response, then think for injectable terbutaline or adrenaline subcutaneous injections or injection magnesium sulfate. If not responding, if hypoxia persists, and if there is some changes, we may have to think for mechanical ventilation. Okay. Next is foreign body. Very common age is 1 to 3 years, mainly less than 4 years, and substances are food and toys. Any child who is afebrile with severe tachypnea, respiratory distress, having choking, gagging, coughing, stridor, and wheezing, you should suspect foreign body. Clinical diagnosis is on that side, you will get decreased air entry. If you go for X-ray, 25% of the cases it is normal, or you can have a radiopaque foreign body. You will get localized hyperinflation, atelectasis, or medication shift. If the foreign body is there in the upper respiratory tract, we can try for this English maneuver so that we can go there foreign body. Last is pneumonia. It is lower respiratory tract infection that involves airway and parenchyma with consolidation of air spaces. Type maybe it may be lobar, it may be bronchopneumonia, it may be interstitial pneumonia. Causes infection, might be bacterial, viral, age according to age, organisms may change. It may be aspiration, it may be foreign body, it may be hydrocarbons. In severe pneumonia, presentation may be high-grade fever, it may be tachypnea, cough is there, pleuritic chest pain is there, retractions, apnea, grunting, and not feeling. It may be same. This is a simple WHO chart to classify the types of pneumonias for the age 2 to 59 months age on the basis of either they may have no pneumonia or they have pneumonia on the basis of fast breathing or chest retractions or very severe pneumonia when there is some general danger signs in the form of not able to drink, persistent vomiting, convulsions, unconsciousness, or some lethargy. And these are the very important for the healthcare facilities. How to treat such patients and when to refer such patients. So, when we are treating with respiratory emergencies, few signs we must consider and that to be taken care. Those are tachypnea, bradypnea, tachycardia, bradycardia, pallor, chest retraction, grunting, stridor, cyanosis, sweating, nasal flaring, paradoxical breathing, fatigue, agitation, change in alertness. There are few signs which are early and few signs are late. This is very important because if you come to know or if you see such type of signs, we should be very aggressive in treating because we know there is a respiratory distress in the pediatric patient, then the chances of going to respiratory failure and later to respiratory arrest is very high. So we should immediately diagnose and we should start treatment. So there are some red flag signs. These are rapid breathing, inability to breathe, cyanosis, sweating, the sleepiness, confusion, loss of consciousness, and red flag sign will suggest that baby is in a that patient is in a respiratory failure. So that immediate intervention is required. So respiratory distress is what? It is abnormal respiration rate and breathing. But respiratory failure is inadequate oxygenation, ventilation, or both. So initially patient is in a respiratory distress, and if you don't diagnose and if you don't treat it at this stage, chances of patient moving to respiratory failure is high. How a word regarding pulse oximeter. It has incredible value in monitoring the patient with acute respiratory distress. But tendency to confuse oxygenation with ventilation is also there because sometimes you will get a normal saturation, but the breathing is not normal. So instead of treating seeing the pulse oximeter, it is not possible to grade the severity of the patient. And the last is that the treatment of all these respiratory emergencies is in the common ways. That is, first is airway patency, second is adequate breathing, and third is oxygenation. If you take care of all these three things, we can treat such patients nicely. Thank you.
Yeah, thank you so much, Dr. Kathar. Your sound was echoing. Have you joined from two devices? Please keep one on mute mode, please. I would now invite Dr. Prakash Vaidya sir for his expert comments on this topic.
Thank you very much, Maha IIP, for this invite. And I think I first need to congratulate Maha IIP for this very innovative programs because this is a very new thing. One is the Tuesday Takes, and last week I was on something called as Maha IIP Case Challenge. Very innovative ways of dispensing and spreading knowledge. So hats off to you. Now at that talk, Dr. Mahesh Mohite made a very interesting observation. He said Maharashtra is full of talent, and I'm really seeing, I would endorse it completely because we are seeing so many new faces and so many wonderful presentations. So to come back to Dr. Kathar's excellent presentation, it is very, very difficult to encapsulate something in 5 minutes. It's much more easier to do it in 1 hour. So really nicely done and the right emphasis. With that, I would like to make a few observations. That one is that as pediatricians, we should realize that the anatomy of the upper airway in children, as well as the collapsibility of the thoracic cage, makes kids very vulnerable to respiratory emergencies, which he pointed out right in the beginning. The other thing is that we were talking about epiglottitis. Now, I'm sure most of us have not seen epiglottitis because after the advent of Hib vaccine, it's all but not there. So we should be, of course, aware of that entity, but I think we should be more focusing on croup, which is something very common, and he very nicely outlined the management of that. Now, regarding bronchiolitis, I would just like to share one thing, that suppose we are really at a loss for a diagnosis, that is the time we take an X-ray. When we suspect a pneumonia, it's not actually mandatory to take it in every case. The other important thing is that today there is a simple antigen test for RSV, which we may not be aware. It costs less than 500 rupees, and you can actually do it from the nasopharynx. It's not a PCR test, it's a point of care test, and you can really get a diagnosis of RSV disease on the spot. So having said that, I think his summation of pneumonia was excellent. And one more thing I would like to add about bronchiolitis, I wish as an intensivist he had made a reference that we do use CPAP as a modality in severe cases. But I think it's very difficult to cram everything in the space of 5 minutes. And at the end of the day, Dr. Kathar has done a wonderful job. Congratulations.
Thank you, sir.
Yeah, thank you so much, Dr. Vaidya sir, for your comments, and Dr. Kathar, thank you so much for your topic. So now we move on to the next topic, which is oxygen delivery modes. It is by Dr. Swati Khot. She is the Assistant Professor of Pediatrics at Government Medical College, Miraj, Sangli. Over to you, ma'am.
Good evening, everyone. At the outset, I would like to thank Maharashtra IIP Women's Wing for giving me this opportunity, and as well as our organizers, judges, and mentors for the excellent guidance that they provided. Madam, I hope my slides are visible.
Yeah, they are visible.
Okay, so today I have been allotted 5 minutes to talk about oxygen delivery modes. Now, we as pediatricians might agree that the most common cause of hospitalization in pediatrics is probably cardiorespiratory system. And one of the most commonly used drugs is oxygen in the hospitalized patients. But unfortunately, oxygen is also one of the most commonly misused drugs, I should say. For any drugs, as for a judicious use of that particular drug, we should be knowing when to use, when not to use, how to use, and how not to use. So I'll try to keep it very simple regarding oxygen also. So we already know when to use. There are numerous indications, clinical scenarios where oxygen is helpful. Oxygen is a wonderful life-saving drug, but most commonly it comes down to either suspected or documented hypoxemia. But apart from hypoxemic hypoxia, there are other causes of hypoxia like circulatory failure or shock, where optimization of that oxygenation is very much helpful. Apart from those typical scenarios, it is also helpful in the cases of increased metabolic demands like severe sepsis, and for short-term uses like post-anesthesia, post-surgery, also it will help. But ultimately, all the case scenarios will be aiming towards one of the 3 clinical goals that we are trying to achieve by giving oxygen. One is treating hypoxemia, of course. Second is decreasing that work of breathing for whatever reason, and decreasing the load on the myocardium and helping it to compensate for whatever purpose. So oxygen delivery system, it's a device which is used to administer, supplement oxygen in a regulated manner to a patient to increase the arterial oxygenation. This system basically will entrain oxygen along with air to provide a fixed concentration of that oxygen. And that concentration we already know is known as fractional concentration of oxygen, that is FiO2. Now, there are numerous systems available in the market so far, which can deliver oxygen to a patient, but which system to use in particular patient, that is the most important thing to learn. And the factors that we consider in selecting a system are the patient's comfort, acceptance, level of the FiO2 that we need to achieve, also the precision of control of that FiO2 in that particular patient that we want. Also the humidification, and in like COVID-like scenarios, we also learned that the economy and the efficiency of that particular device also matters. So coming to the types of the various oxygen delivery modes, first, there are various systems in which we can divide these devices. Most commonly used ones are either on the based on the degree of dependency, where we can divide these systems into high, medium, or low dependent systems. Now, high, medium, and low dependent system means the additional ventilatory support that these devices provide, and that range from high dependent like mechanical ventilation to the low dependent devices where the patient is spontaneously breathing and we just supplement the oxygen without any ventilatory support. The medium ones being CPAP. Now, based on the design of that particular device, we can crudely divide these devices into high flow, low flow, and the reservoir system. I'll come to these systems later on in detail. Based on the performance of that device, we can categorize into two as fixed and variable performance devices. Now, fixed performance devices will deliver a particular FiO2 very efficiently, and the precision of that FiO2 will be good, whereas variable performance will in turn, the FiO2 will be variable depending upon the patient's various factors, including the patient's respiratory pattern. Now, the low flow system, here the gas flow is lower, insufficient to meet the patient's peak inspiratory or the minute ventilatory volumes. So the oxygen provided will get diluted with the air whenever the patient is supposed to trying to breathe faster. Then the air will be coming in more and the FiO2 will be diluted. Hence the FiO2 will vary according to the patient's ventilatory pattern, and hence these kinds of systems will be labeled as variable performance devices. The most commonly used low flow systems in the practice are nasal cannulas, nasal catheters, or transtracheal catheters. In these systems, commonly we use a low oxygen flow at the rate of about 1 to 4 liters per minute, and the oxygen FiO2 ultimately that we can achieve is up to almost 40 to 50%. Here I would like to add just a note that in low flow devices, especially in the newborns, we don't recommend now. There are suggestions that the flow more than 2 liters per minute are not recommended because administration of positive airway pressure can occur if we use a higher flow rates with the simple nasal cannulas. Now, the second category becomes a high flow system where obviously the oxygen flow used is higher than either the patient's minute ventilatory requirements or even the patient's peak inspiratory efforts. So at any given point of time, the oxygen flow will exceed any of these flow rates, and hence that the FiO2 that we are trying to deliver will be kept constant and it will not be dependent on the patient's ventilatory pattern. Hence, it will be labeled as a fixed performance device. The commonly used high flow systems are Venturi mask that we all are aware of, and the more important one is the high flow nasal cannula. Now, few people use this reservoir system as another category. Now, reservoir system is the system where we use that stores the reserve volume of oxygen that usually equals or exceeds the patient's tidal volume. That will be that can deliver a moderate to high concentration of oxygen. But again, these will be variable performance devices. If the reservoir volume is exceeding well exceeds the patient's tidal volume, then these devices can also work as somewhat fixed performance devices. The common ones that we use is simple face mask, partial rebreathing or non-rebreathing mask, and the tracheostomy mask. Now, I'll try to just enumerate the merits and demerits of the few commonly used devices. Now, nasal cannula, we all used it. I'm not going to go into the details of how to use it. Obvious merits is, of course, the easy to use, easy to fix. They keep the patient's hands free, so patient's mobility is preserved. There is not much interference with even the airway care, so doctors also prefer it. And obviously, the low cost and compliance are added benefits. But the obvious demerits include it is unstable, easily can get dislodged, especially in the younger cranky infants. The high flow will be uncontrollable. The nasal trauma and the mucosal irritation can occur, especially if the patient is fighting the cannula. And FiO2 can be inconsistent, that is a nasal low flow device. The rough estimation of FiO2 that can be provided by nasal cannula, the usual formula that we apply for every liter of oxygen per minute that we provide through cannula, the FiO2 raises by about 4%. So above the approximate 20% of the air, as we go on increasing the flow rates, FiO2 can be increased, and if we use the flow rates of 6, it can be raised up to 44%. The catheters, nasal catheters, these are soft catheters. After lubrication, we can just put it inside the nose till just above the uvula. They basically are much like nasal cannulas, with the obvious merit of being a better stability than the cannulas, but the difficulty of insertion, increasing the back pressures, and the regular changing are the obvious side effects, and that can lead to provocation of gagging aspiration. And certain nasal disorders like polyps or deviated septum can block the insertion. Transtracheal catheters not commonly used, but in cases of long-term treatment, whereas a long-term oxygen treatment is needed, then we can use this. But the obvious demerits include the surgical complications, infection, along with mucus plugging, and the track can get lost. Another commonly used device is a simple face mask. Obviously, it is a reservoir kind of system. Moderately, it delivers moderate but variable FiO2, but it is good for patients where nasal passages are blocked for one or the other reason, and patients are mouth breathers. It is very easy to use, but again, there are certain demerits like it is uncomfortable, it will interfere with the airway care, and if we want to deliver a proper FiO2, the proper fitting is needed, and the flow needed should be more than 5 liters per minute. Now, partial rebreathing mask is again simple mask along with an added reservoir, but herein we don't have any walls. So whenever we try to exhale, that exhaled air in the initial first part of that exhaled air will enter that reservoir, but mostly as that part is coming from the anatomical dead space, the lower the concentration of CO2 will be still low in that air. And whenever the child tries to inhale through that first part along with the oxygen coming from the tubing will enter, will be provided for the inhalation. So this will try to increase the FiO2 to about 60 to 80%. And here the flow rates required are more than 8 liters per minute. We can go up to 15 liters per minute. But for this mask to work properly, we should make sure that the bag should remain inflated most of the times, at least 1/3 to 1/2. Then the going ahead of the same mechanism, we have got non-rebreathing mask, where we have got a mask along with a reservoir with 3 unidirectional walls. 2 of these are expiratory and 1 is inspiratory. So during inhalation, there is no air entering from the side ports, and during exhalation, no exhaled air enters the reservoir. So there we can achieve even higher FiO2, and FiO2 can go even as high as 0.9 to 1, and the flow requires are more, and we need at least flows of 10 to 15 liters per minute. Then we know the Venturi mask with the color-coded system, which works on Bernoulli principle. These will have mask along with this jet orifice. This is basically works on the principle where there is a jet orifice through which air is passed in a fast way. Now this air will, with the shearing forces, will suck in some air. Oxygen will, with shearing forces, will suck in some air, and that concentration will depend on the jet orifice as well as the entrainment ports, and that concentration will remain stable if we keep those flow rates stable. So here the main advantage, it will be a fixed performance device. We can keep that FiO2 constant between the range of 0.24 to 0.6. Now, high flow doesn't mean, or the fixed performance doesn't mean that the high oxygen levels or high FiO2 is needed. We can go for a lower FiO2, but that FiO2 will be remaining constant over time. In high flow nasal cannula, we have all been using this. This device delivers heated and humidified oxygen via special devices, and rates used are high. Approximately 2 liters per kilograms per minute are recommended, and in infants it goes to about 8 liters, and in children or adults it goes up to 40 to 50 liters per minute. And the added advantage of high flow nasal cannula is it will create some positive nasopharyngeal pressure also, and it is a very reliable fixed performance device, and the clinically very useful in common scenarios like bronchiolitis. So we have got n number of devices, but ultimately the choice depends on the 3 factors. The 3 P's important is the purpose for which we are using, the disease condition that we are using, and that means that the FiO2 that we require in that particular patient, and the precision of that control that we require. Then the patient characteristics, like which kind of age group of patient that we are providing this support to, and the particulars like the nasal catheters and all those nasal passages of that particular patient, and also the performance of that particular device that we are considering. So goal is to match the performance characteristics of that equipment to achieve the objectives of treatment and the patient specific needs. Now, along with that, I'll just like to add another P to this, that is use of pulse oximetry, and that will be very much useful for monitoring the effectiveness of the oxygen therapy, along with, of course, arterial blood gases and clinical scenarios how the patient is responding to our treatment. So just before parting, I'll just like to add a few notes that in special conditions like young agitated infants, it might become difficult to use any of these devices. So even the blowing oxygen past a patient's face can be used, as her has already discussed some time ago. It is not a reliable means of oxygen delivery, but temporarily it can help the patient, especially when the child is agitated and not dealing with any kind of other device. Now, hoods and oxytains we already used, and that also can be used in the especially the young infants. Now, common mistakes while giving oxygen, either we choose the wrong kind of device, not suitable for that particular patient or for that particular disease. Like suppose it is a chronic hypoxic patient where we don't want hyperoxia as well, then we might require a fixed performance device rather than a high FiO2 delivering device. Then the wrong size, approximately for each device, there will be particular guidelines. We need to follow all the guidelines for choosing the correct size for that particular patient. The flow, keeping the flow too little or too high. For example, with hoods, if you don't give enough oxygen of about 10 to 15 liters per minute, then there will be CO2 buildup and there are chances of CO2 rebreathing. Or too high flow, as we already discussed in cases of newborns. Then the humidification, it is very much important to humidify and keep the oxygen warm, especially if we are bypassing the natural humidifying areas of nose and upper nasopharynx, like in mechanical ventilation or tracheal base. But apart from that, even if we are using high flows, then we need to humidify and warm that air properly. And of course, not keeping a proper regard for hygiene. And the last important thing is probably not keeping in mind the disadvantages of hyperoxia, because we monitor for hypoxia very well, but we should consider the side effects of hyperoxia also. And in the end, I would just say that it is also a drug, and we should we should give oxygen therapy with certain end measures to avoid the side effects of hyper as well as hypoxia. Thank you very much.
Yeah, thank you so much, Dr. Swati Kot, madam, for excellent presentation. Now I request Dr. Prakash Vaidya sir to have his expert comments on this topic.
Stop the screen sharing.
Yeah, ma'am, stop this. Pallavi, madam, please mute all other speakers, all other persons.
Yes, ma'am. Yes.
Yeah.
So that was a great presentation, Dr. Swati. A little long, but then it's very difficult to get all the devices in 5 minutes, so I can understand that. And thank you very much for even being so receptive to my suggestions. Now you said it all in the beginning and at the end when you said that oxygen is a drug. Now that is something we tend to forget, because that is the perspective that we start oxygen, we start it and we forget it. It is a drug like any other with its own effects and side effects. So that is one thing that we should never forget. And I think you really emphasize that so well. The other thing is that the clinical goal that we want to achieve, what do we really want to achieve when we start oxygen? Is it a supportive thing? Is it to treat hypoxia or is it to treat something else? The other thing is that let's remember that so many times the patient is doing well on a hypoxic drive, and we will eliminate that drive if we give oxygen unwittingly in certain clinical situations. So that is one thing that we should be aware of. And having said that, you explained everything else so well, and especially in young crying infants, sometimes by giving oxygen, they become more agitated and it is counterproductive. So they must be on the mother's lap. And sometimes to begin with, you may give a side blow oxygen because that will reduce the agitation and make them more receptive to a little more aggressive modes of oxygenation. So I think all in all, that was a wonderful bird's eye view which you gave us, and an excellent presentation which told us that targeted to the patient, be aware of your patient, be aware of your goals, and be aware of the basics of your devices. So thank you very much again.
Thank you, sir.
Yeah, thank you so much, sir. And Swati ma'am, with your 3 Ps, Dr. N.K. Subramaniam has written in the chat box that the 4th P is pediatrician. Yeah. So now moving to the last topic of the session, it is by Dr. Swapnil Patil. He is the pediatric consultant at Amravati. His topic is chronic lung diseases in infants. Over to you, doctor.
Okay, thank you. Good evening, everyone. My topic for today's Tuesday talk is chronic lung diseases in infants. Quickly, we go through introduction, followed by definition, etiopathogenesis, diagnosis, treatment, and preventive therapy. Now, the chronic lung diseases, which are seen in infancy, rather less than 2 years, are classified into different categories, and these are diffuse developmental disorders, which includes acinar dysplasia, congenital alveolar dysplasia, alveolar capillary dysplasia with pulmonary vein misalignment. Then those are those with growth abnormalities reflecting deficient alveolarization, which includes pulmonary hypoplasia, chronic neonatal lung disease, that is premature related chronic lung disease, bronchopulmonary dysplasia, and acquired chronic lung disease in term infants. And again, structural pulmonary changes with chromosome abnormalities as seen in trisomy 21 and associated with congenital heart disease in chromosomal normal children. Then another category is specific of undefined etiology that includes PIG, pulmonary glycogenosis, and neuroendocrine cell hyperplasia of infancy. And again, a surfactant disorder, which includes SPFTB genetic mutation and ABCA genetic mutation. Now, to start with, BPT is most common chronic lung disease seen in premature infants who required mechanical ventilation and oxygen therapy for acute respiratory distress that results from imbalance between lung injury and repair in the developing immature lung. By contrast, the term chronic lung disease has been used to describe the term infants with variety of chronic condition oxygen supplementation. The condition might be congenital diaphragmatic hernia or pulmonary hypoplasia. Now, by definition, BPD includes an oxygen requirement 28 days postnatally, and the disorder is graded as mild, moderate, or severe on the basis of supplemental oxygen requirement and the gestational age. Now, for infants born at less than 32 weeks of gestational age who remain in oxygen for first 28 days at 36 weeks post-menstrual age, mild BPD is requirement of no supplemental oxygen, moderate BPD is requirement of supplemental oxygen less than 30%, and severe BPD is requirement of more than 30% of oxygen and or positive airway pressure or ventilatory support. For infants more than 32 week gestational age, BPD is defined as a supplemental oxygen requirement for 28 days, for more than 28 days, but less than 56 days postnatal age or discharge home, whichever is earlier. And again, this is categorized into 3: mild, moderate, and severe. Mild BPD is breathing at room air by 56 days postnatal age or discharge home. Moderate BPD is need for more than less than 30% oxygen at 56 days. And severe BPD is need for more than 30% oxygen and or positive pressure ventilation or nasal CPAP at 56 days postnatal age or discharge home. As you all know, the BPD, the etiology is multifactorial and involves disruption of lung development and injury due to antenatal or postnatal factors. Antenatal factors may be due to intrauterine growth retardation or maternal smoking. Postnatal factors like oxygen therapy, ventilatory support, or infection. However, occurrence of BPD is inversely proportional to gestational age and birth weight. Lower the gestational age or lesser the birth weight, more is the occurrence of BPD. Additional associations includes low PaO2 during treatment of RDS or using high PIP. Associated occurrence more with male sex, family history of atopy or asthma. Again, presence of interstitial edema that may be due to air leak, fluid overload due to overperfusion, or increased pulmonary perfusion due to PDA are also contributing factor, and genetic polymorphism also seen with associated factor. Then how to diagnose? The earliest evidence of BPD is the delay or difficulty in weaning a preterm baby with RDS from ventilation. After weaning, the infant continues to have tachypnea, subcostal retraction, wheezing, and varying degree of hypoxemia and hypercapnia. Chest X-ray finding varies from a clear lung field to a finding that include diffuse haziness and a coarse interstitial pattern, which may reflect atelectasis inflammation and or pulmonary edema. Patients are often hypoxemic and hypercapnic. If ABG is done, it may show low PaO2 with raised PaCO2 and a combined respiratory metabolic acidosis like picture. ECG may show right ventricular hypertrophy due to impending cor pulmonale, and PFT shows evidence of increased airway resistance and decreased lung compliance. Echo may be required to exclude existence of PDA. If you see the treatment of BPD is multidisciplinary, includes nutritional support, fluid restriction, drug therapy, maintenance of adequate oxygenation, and prompt treatment of infection. The calorie intake should be enhanced to provide 150 to 200 kilocalories per kg per day orally, or 115 kilocalories per kg per day through TPN to sustain growth. Severe BPD who requires prolonged mechanical ventilation, try to use low tidal volume, which minimizes pulmonary injury. Acceptable blood gas concentration includes permissive hypercapnia, targeting PaCO2 between 55 to 65 mmHg. with pH more than 7.2 and PaO2 50 to 70 mmHg with oxygen saturation targeting 91 to 95%. Gradual weaning should be attempted despite elevation in PaCO2 because hypercapnia may be the result of gas trapping. Diuretic therapy can be used for a short term. IV furosemide can be given. However, as it is associated with systemic complications, one can shift to oral thiazides once the baby is accepting enteral feed. Nebulization with salbutamol is effective as has less side effects. Theophylline can be used in those with recurrent and severe bronchospasm as it decreases pulmonary vascular resistance and increases lung compliance, probably to direct smooth muscle relaxation. A trial of steroids is indicated after 2 weeks in babies with HMD on assisted ventilation, and inhaled steroids are effective to facilitate early extubation of ventilated infants with BPD. Now one can also for prevention strategy, there is evidence to suggest that vitamin A 5000 international unit IM 3 times weekly for 4 weeks may reduces the incidence of chronic lung disease in extremely low birth weight disease by 10%. Upcoming therapy for prevention of BPD is administration of human superoxide dismutase to babies less than 27 weeks intratracheally every 48 hours while intubated resulted in an approximately 50% reduction in asthma medication, emergency room visit, and hospitalization in first year of life. However, this treatment is investigational. Again, caffeine citrate started during first 10 days of life in extremely low birth weight babies reduces the incidence of BPD from 47 to 36%. Antenatal administration of DEXA, as we all know, if labor starts before 34 weeks, antenatal addition of DEXA will reduces the occurrence and incidence of RDS and thereby bronchopulmonary dysplasia. Effort should be made to treat infants with RDS with minimal effective airway pressure and FiO2 for the shortest duration of time. And again, high frequency jet or oscillatory ventilation is associated with decreased risk of chronic lung diseases. IV infusion rate should be kept low to decrease incidence of pulmonary edema and opening of ductus. And if ductus is identified, pharmacological closure should be attempted. Thank you.
Thank you so much, Doctor. Now over to Dr. Vaidya sir for the expert comments to Dr. For his topic.
Thank you, Dr. Swapnil. That was a really concise presentation and you made all the salient points very well. A couple of things now, as more and more babies are being born small for date, more and more babies, very low birth weight as well as very preterm babies, we are getting a higher incidence of BPD. So all of us should be focused on prevention of BPD as much as the management. So the focus of prevention is, of course, as you rightly said, that we respect oxygen, we try to give a lower SpO2, we give a PEEP of 5 to 7, and we allow pervasive hypercapnia. So, and low tidal volume. So if we all follow that, probably the incidence will be less. But there was a very interesting study recently, which was published, which said that postnatal dexamethasone had some role in preventing BPD. And compared to hydrocortisone, where hydrocortisone was also tried, but it did not give good results. So there is a role of postnatal dexamethasone to prevent BPD. And as we see in practice, when a patient comes with BPD, we often confuse it with other respiratory problems. So I think, though you did mention that bronchodilators can be used, one of the common references that is reliable is UpToDate. And they said that there is no role of bronchodilators and no role of steroids, either systemic or inhaled. But all the other supportive treatment which you mentioned, of course, plays a very important role. So I think in this day and age, we should be aware of more on how to prevent BPD and recognize and manage it effectively. And I think your presentation said it all in a very concise manner. Congratulations.
Thank you, sir.
Yeah, thank you so much, Swapnil, and also Dr. Vaidya sir for your expert comments on this last 3 topics. And now I again welcome our MMC observer of today's, Dr. Rajendra Kulkarni sir. Are you there, sir? Can you please unmute and open your video? Pallavi madam, please help him.
He's there. I gave him all the
Yeah.
Also, he'll do it maybe.
Yeah. So sir has been there for our MMC observer. We have got today 1 point. And so we welcome him on behalf of MAHA-AP and Women's Committee. Now we come to the end of the session where now we are having to sit tight in these seats. And then we are going to face our Dr. N.K. Subramaniam sir, who is a mentor for today. And he is going to have a rapid fire round with our speakers. So Subramaniam sir, are you there?
Yes, I'm there.
Sir, I want to introduce you within 1 to 2 minutes.
Yeah.
May please permit me?
No, it's okay. Don't worry.
Sir,
There are hardly 80 participants. It may come down. So you can be brief.
Okay, sir, I can be. Okay, thank you so much. Professor Subramaniam N.K., he is presently medical superintendent at Saptagiri Institute of Medical Sciences and Research Center, Bangalore. He is also Vice President, South Zone CIAP for 2022. He is a national faculty speaker and speaker for many state, national, and international level conferences. Also, he has conceived the popular Respinars. He is also editors of many journals and organizational abilities in joint organizing secretary of National Conference in Pediatrics Pedicon 2009, organizing secretary of Respicon 2017 and Carnicon 2018. He has publications to his name in various textbooks. He is currently chairperson IIP National Respiratory Chapter 21-22. And he has many awards to his name. For naming few, he was awarded Best Secretary, Best IIP District Branch Award for Karnataka State 2005-6, 2006-7, and also has conveyed oration at Srimati Parvathamma and Halappa oration at Lakeside CME 2020, Pedicon 2010 oration at AP Pedicon at Kadapa, Sri Tirumala Rao oration at PATS 2019, and Dr. Devaki Nandan Karwa oration at Mahapedicon Midterm Kolhapur, and also is socially associated with Lions Club, along with conducted many camps in rural areas. Over to you, Dr. Professor Subramaniam sir. Now the mic is in your hand.
Okay, I wanted to have one new style of doing things rather than me speaking more. Can I have the first speaker, Dr. Sinha, Dr. Mangai Sinha? Can you just say hi? Okay,
Yes,
in the upper respiratory disorders that you have spoken for long, there are, what is one single message that you wanted to give? What is that troubles you most in upper respiratory disorders when you are sitting in your clinic?
Upper respiratory disorders are extremely common in our practice, but they are the ones which are extremely difficult to treat, and more so to convince the parents that we don't really need to treat.
So you are coming to the heart of it. Let's be very brief. You mean to say counseling is the most difficult thing?
Yes, sir.
Do you agree?
Counseling parents to admit or be patient that what we are less is more, or if we treat, it will take 7 days, like they say, and if we don't treat, it will take 1 week.
I think the message is simple. Parents want drugs, but you want advice. There is a huge mismatch.
We can give them medicines because we obviously need to write something. I do private practice, so patients come to me and I can't really send them.
Yeah, how will you downgrade your own prescriptions for a patient in counseling? This is the real thing. I think this is the take-home message. Let me tell and answer what I do, because this is most important. All of us are rationally irrational or irrationally rational at many times, but none of us are rationally rational. Let's accept this point. You all agree? Just say yes, no, hi, yes. So how do we agree on the point that I will play my prescription, but I will downplay it while I'm delivering it? What I do to the mothers is I will tell her, look here, on your compulsion, just because you are too tense, you are too anxious, I'm writing couple of drugs, but remember, they do not do magic. What I'm trying to tell you is most important than the drugs that I have given to you. So please listen to my advice, recognize the danger signals, wait for a self-limiting disease, allow the nature to relax and do its best. While if you feel needed, too much unbearable or whatsoever, then you can use these couple of drugs. Can this be a simple take-home message for all upper respiratory tract infections, because the practitioners are in dilemma. You people talk of so much of theory, but when we visit your clinics, you will have hundreds of prescriptions of the same. So therefore, my dear friends, the brain says, do not write drugs, but the heart says, write some drugs. You have to connect the brain to the heart, and your heart should listen to your brain. And at sometimes don't be so accurate, because sometimes your brain has to listen to your heart. Those of you who have cardiomegaly, writing too much of prescriptions, please have hydrocephalus and microcardia. And those of you who have hydrocephalus and small cardia, please have some normal heart and a shrunken brain. So see, balance between the brain and the heart, and ultimately balance your prescriptions. The last word from me for upper respiratory tract infections is, along the highways, do not use antibiotics. What do you mean by highways? Nose, and then the nasopharynx, the pharynx, the larynx, trachea, bronchi, and bronchioles. Do not use antibiotics. This is called as highway. Along the sideways, use antibiotics. What do you mean by sideways? Sinuses, use trachea tube and then middle ear. These are sideways. When you go to the sideways, what happens is there is obstruction, stasis, and infection. Am I clear? It's very simple. The crypts of the tonsils are also sideways. And therefore, there are micro abscesses in the tonsils which demand an antibiotic. On the contrary, adenoids do not respond to antibiotics for simple reason that there are no crypts in the adenoids. The same lymphoid tissue behaves differently because of anatomy. I think we need to understand anatomy. The more complex an anatomy, you need antibiotic. The less complex an anatomy, you would not require an antibiotic. The last sideway is alveoli, dead end, and therefore you have a stasis and a bacterial infection, and therefore bronchiolitis do not require antibiotic, while an alveolitis, which is pneumonia, would require an antibiotic. I think this is pretty simple, and you don't complicate yourself in remembering too many things. Congratulations to you, Sina. I think you have done a wonderful job. And can all of us clap for her? Okay, that's so nice of her.
Dr.
Next
Subbu
is
sir, Dr. Subbu sir, one more point. Most of the time, the patients say cold and noisy respiration, and most of the time the cold prescription are given. No cold prescription to the noisy respiration and the gar.
Okay. So that I used to call in most of the webinars as Gora syndrome. Gora syndrome has to be treated with kiri mothers or chit fathers with a patient pediatrician. Okay, that's all that is required. Nothing to be done. So that's excellent, and therefore we conclude the first session with some simple messages, but these are very hard and very difficult to follow. Very easy to speak on phone or on a webinar. The second, I think it's recurrent respiratory infections by
Dr. Preeti Joshi.
Dr. Preeti Joshi, you are here?
Yes, sir.
It was excellent session. What is the most important thing that you face on your desktop or on your table in practice tomorrow when it comes to recurrence? You forget all the slides that you have made.
Recurrence of parents coming to us, taking the same complaint.
Taking the same complaints, coming again and again.
Yes,
that's
it's difficult to, yes.
Yes. So therefore, my dear friends, pediatricians, she is rightly spoken from her heart, not from the brain, that the recurrence is pretty normal given the child. So therefore, the normal recurrence with over anxious parents is the most common presentation. Let's all agree on this point.
Yes.
Normal recurrence. And you will see that in first year of your clinic, they come 7 to 8 times. Second year, they come 3-4 times. Third year, they come once or twice. Fourth year, they hardly come. You will be thinking that they must have gone from Renu to Sunil, said, the patient, because so I have lost that patient, they're not coming to me, they must have gone to next neighboring pediatrician. That's what you feel. You all have you got this feeling or not in the gut? You will see them less and less. Oh my God, I have lost this patient to the next pediatrician. Actually, you'll be very happy and surprised when they come back with the second child. Oh my God, I have retained the mother. I don't know whether this is a gut feeling. At least to me, it has happened many a times. So therefore, remember, this normal recurrence is a very important phenomenon in practice. And only when you have an abnormal child in growth and development, you investigate. Otherwise, if the child is growing well, it's often normal. And one important disease with a normal growth is asthma and wheezing, which you have to recognize. So please differentiate between true recurrence and a flare-up of a persistence. This is important because the symptoms never come back to normal in a persistent disease versus a true recurrent disease where symptoms come back to baseline or normal. This history should ask. The mother tells you, whole of July child is not well, sir. The cough has not gone at all. You have given n number of drugs. If you ask her 1st of July, how was the child? She says, sir, too much of symptoms. 3rd of July, yes, sir. 5th of July, sir, little bit less. And 10th, 9th, sir, those 2 days were fine. But again, it came back. So she doesn't want you to accept that 2 days it touched the baseline. I don't know whether I'm speaking with same sentiments as that mother. Please understand, if she says whole of July, it means 1st of July and 30th of July, the child had problems in between. Even though the child is normal, she wants to overplay the symptoms and therefore want you to write more medicines. I think this is the most important message I want to give for recurrence. Please remember one small line from me. Recurrence is because of environmental factors like pollution, macro environment, micro environment, microbial, functional, etc. While persistence is always because of anatomy. Persistence is never because of environment. Persistence disease, when a disease persists and a child doesn't grow, please do radiological evaluation, bronchoscopy, whatever you want to do, you will get something. Please remember this point. This is very small time for me, so therefore I can't explain all the persistent diseases. If the child is not growing well, and if the symptoms persist, look for an anatomical abnormality. This can be a simple key message that I can give. So hearty congratulations to Dr. Joshi. Well done. Can we all clap for her? It was excellent. Dr. Sunil is smiling and he's breathing well because his aerosol delivery was excellent and he delivered it perfectly. All that I wanted to ask you, what is the most difficult thing that you face in aerosol delivery in practice? Inhalation therapy.
First is convincing the parents. Second, I can say there's a technique. N number of that times the technique is faulty. You tell them still the technique is faulty.
Okay, can I be little witty? How often convincing to yourself was difficult?
So we try to convince.
No, wit means sometimes we are not convinced ourselves and we are little shaky and we wanted to play in between. Has it happened to you?
No.
No, that's fine enough. At least you are on either this side or that side. I think you're a fair man. I can read from your face. Okay, fair enough. Some are like judgmentally, some may face some problem. Can I share a small experience of mine with regard to aerosol delivery? I was sitting in Bengaluru and I was explaining to a mother, one who walked in, everything I told, like this is spacer, this is inhaler, this is the micro diameter size, that, cost effective, you will have no problems. I took 30 to 35 minutes to explain that mother. She told me, you are the best doctor in Bangalore. And I felt little happy because I was beginning my career and I thought it's fantastic. Sunil, you know what happened later? After listening to the whole story, she told, doctor, you are so nice. Actually, I'm the neighbor of the mother. Please explain again. The mother is waiting outside. So I think what is required whenever you counsel for the pediatricians is to realize that you know to whom you are talking, what you are talking, what are the contents that you have to do. And that is the birth of the video that I have made. Because then what I started doing was watch this outside, sit outside, watch this for 30 minutes and come back. You know, you don't have to repeat. If you have a long conversation, you make your own videos so that you don't have to repeat each time, because your enthusiasm may not be same always. You may be busy at times, you may be emotional, you may lose your temper. Therefore, I request you, all of you, to have your own videos, how to give paracetamol, how to give antibiotics, how to give drops, how to give ORS, how to do tepid sponging, or how to treat a fever at home, when to reach you. Can you make 10 to 15 videos, IAP? For I request you to take this forward, make small mini videos, and let these videos be in wide circulation. So we'll see all our friends, maybe from the same place like Nasik. If all the pediatricians speak the same language, they will not go to the next pediatrician. They'll stay back, because seeing that they are very good friends. I think this is the small message that I want to give as far as aerosol delivery is concerned. Can we clap for Dr. Sunil? Excellent. And Sunil, you are also handsome. Thank you very much. A very nice man. So I was really, it was pleasant to talk to you in the morning when I spoke to you for a long time. Thank you so much.
Sir, just
Next.
a minute. Sir, just a minute. Dr. Rajendra Kulkarni, sir, senior pediatrician who is MMC observer. He is there.
Yeah,
Sir,
welcome.
welcome,
Yeah,
sir.
Welcome, sir. And we would like to have the blessings from you, Dr. Rajendra Kulkarni, sir.
Yes. Hello.
Yes, sir. Welcome.
Thank you. Hello, everybody. And I am very pleased to see my old friend who now looks old. That is Subbu. Nice to listen to you, Subbu.
Thank you. Thank you. You are my CR, Chief President. How can I forget you?
CR is always CR. Okay, go ahead. I am very happy to see you progressing so much, being a national faculty. Somebody here was asking me what is the topic of today's CME. I said Subbu is talking, that means it must be respiratory. So much is your name synonymous with respiratory, pediatric respiratory. So keep breathing respiratory, and all the best. All the best, Amol. Go ahead. Thank you.
Thank you, sir. Yes, sir. Subbu, sir, you carry on. Now, next one is Dr. Ashwin Kathar.
Dr. Kathar?
Yes, sir.
Are you from Qatar or you are from Maharashtra? So I was just trying to see.
Maharashtra.
Okay. Maharashtra. Pediatric respiratory emergencies was excellent. Now, can you recollect from your practice one incident where you have picked up an emergency and one incident where you have missed an emergency, just for the sake of it? You don't worry about the slides. Please share with others. Where you felt next day, oh my God, I should not have done that.
So one emergency I picked up, it is what electric shocks.
Okay.
It was lightning. And in front of me, that lightning was happened, and he was pulseless, and there was no breathing. I immediately took, and the age of that patient was 22. So I intubated, I resuscitated, and he came out.
Excellent. So what is the problem for a pediatrician when he faces emergency? Do you think all the textbook of Nelson, the webinars, the modules come to you, or you will be just short of breath? Hello, Dr. Kathar, can you hear?
Yes, sir.
Now, what is that the pediatrician will face the problem? Do you remember all the skills? Will you remember the dose of adrenaline, or will you remember when you face that you have to give oxygen, or will it all be choking at that point of moment?
It will be choking at that time of moment. We have to act accordingly with the situation. We have to handle the situation.
So what is the message you want to give to the pediatricians? To read pediatric emergencies or to prepare for pediatric emergencies?
Prepare for pediatric emergencies.
Excellent. So your clinic should have a dose of adrenaline. It should have an oxygen. You should have the things in place. Your sister should know what to give in your right hand or left hand, rather than reading big protocols in respiratory emergencies. Do you agree on this point?
Yes, sir. Yes, sir.
That's all is the simple message. But what I wanted the pediatricians to know, this is most confusing for students and pediatricians, which I faced in many conferences. What is the difference between the severe respiratory distress and respiratory failure? The severest form of respiratory distress, and when it actually fails, What is the line of demarcation? It's actually very thin, but I will tell you, when you read books, it's pretty simple, but you have not understood them. It is just that as long as the compensatory mechanisms are there, it is distress. And when it decompensates, it is failure. Is this simple? If the nose is flaring, if the chest is breathing fast, accessories are working, this, that, etc., it means that it is trying to compensate. Therefore, it is distress. And when it fatigues, then it is a failure. Is this pretty simple thing that once there is a distress, you can assist in breathing. But when there is a failure, you have to act fast and ventilate the child with positive pressure ventilation. This is very, very important. It could be even with bag mask, even if you don't have a ventilator. And I think, thank you, Dr. Katar. It was wonderful and it was pleasant to listen to you. And I think the audience got the right message. Can we clap for him?
Thank you.
Thank you so much. Next is oxygen delivery by Dr. Swati. Dr.
Yes,
Swati. Swati, you are here?
Yes, sir.
Yeah. Now, what is the problem? Do you think all pediatricians know oxygen delivery, or staff nurses know oxygen delivery, or ward boys know oxygen delivery systems? Please be honest.
Usually, sir, in practical scenario, we just order oxygen, but the actual administration is done by at least the staff, or some places might be even class 4 workers. We don't know, but at least the staff.
Let us all confess and thank our colleagues who are really helping us to give oxygen for our babies and children. And I think it is high time that the pediatricians do not feel ashamed. And tomorrow, please go to your clinic, learn how to open an oxygen cylinder, how to regulate, how it is filled, visit an oxygen source. For example, you may have a tank or a jumbo cylinder, or maybe a plant. Visit and see how this oxygen is done, delivered, how the central oxygen is planned, so on and so forth. Please ask your anesthetists. If you don't have any other teachers, they will teach you. It's very, very important. Now, only message that I wanted to give to the audience is hypoxia that is correctable. Be happy. Hypoxia that is not correctable with oxygen. Please remember, it could be obstruction, it could be failure, it could be a foreign body, it could be a systemic disorder like methemoglobinemia, so on and so forth. This is most important. Second thing often forgotten is monitoring after starting oxygen. After starting oxygen, you give highest dose and we are very happy and we tend to relax. Please remember, if SpO2 is falling below 92, you are worried. But let me tell you one important message today. All of you listen to me, Renu. This is most important. If somebody's oxygen was 99 and it became 95, it has not gone below 92. From 99, it has become 95. Then also he is hypoxic. All of you agree on this point? Please type yes in the chat box. Do you agree? From 99, he has become 95. According to any definition of textbook, he is not hypoxic at 95. Therefore, the trend is more important than any value. And what we write in the case sheets, do we write trends or we write one value in the morning or evening? There will be only one record. This is the drawback of our system. Please remember that we should have a continuous monitoring of oxygen by a simple status, by simple pulse oximetry, which all of us should become familiar. Can we clap for Dr. Swati? Excellent presentation, and you have been wonderful. Now, lastly, Dr. Swapnil, I think I'm falling short of words. You are too much a Rahul Dravid on CLD. Like fantastic, giving no scopes for any mistakes. And you nicely told what it means, a neonatal lung disease versus chronic lung disease versus a diffuse lung disease. It was excellent. And mind you, for the sake of pediatricians, remember only one thing. If you have hypoxia, you will usually have some interstitial disease. When you don't have hypoxia, you will usually have other diseases like parenchymal, airway, etc. Although this is not a good classification, but when hypoxia is disproportionate to signs and symptoms, please think of an interstitial element, and that's very, very important for us. So that could be a simple message from my end. And Swapnil, do you want to recollect any disease, any patients that you have treated with budesonide or something anytime in your practice? Can you share one moment, if at all?
Sir, actually last month we had a baby referred from a tribal area, around 21 days, and he's oxygen dependent. We are given a trial of steroid, and gradually the oxygen tapered off. The baby was discharged on 46 days.
Okay, I think Dr. Prakash Vaidya, I should compliment him for bringing out that point on dexamethasone. When you don't know anything, give dexamethasone. Most of the times things are done. So steroid is a magic drug. Steroid is the best friend for a pediatrician, and the best friend for a steroid is a pediatrician, and best friend for a pediatrician is a steroid. I think this is in simple. A smallest thing somebody was asking about mild bronchiolitis, don't do bronchiolitis, do something, and in severe bronchiolitis, do everything. So this is all the message from my end. Maybe these are simple messages, but they mean a lot in your practice. But I would love to log on to MahaAP. I have given a word to Dr. Amol, who is Anmol Hire of Maha, who told me that we will have a workshop on all youngsters on Zoom as to how to be a good faculty, how to deliver precisely, and how to stick to time, and how to be on the point. All your PowerPoints are excellent. Let me tell you the last line, Renu, with your permission.
Yes, sir.
How to make PowerPoint slides in one line. You should not have text. You should have only points. The moment you have text, then the purpose is defeated. So a PowerPoint PPT should have points, and the points should have power. That's when it becomes PowerPoint. So therefore the point should have power, and your power should be converted into points. So a point should have power, and power should have points, and that is what is PowerPoints is all about. And this is the most powerful tool of delivering the messages. May I request all of you to be the powerful speakers of tomorrow. Maybe the lovely ones I watch on forever, and I love to be an audience for all of you in future. And thank you very much once again, MahaAP, for giving me this opportunity, and all my friends from Maharashtra, and Rajendra Kulkarni for being my chief resident who taught me ABC of pediatrics. Thank you very much.
Thank you. We lastly clap for Swapnil also, and also Subramaniam sir. Yeah, now we come to the end of this session. I request Dr. Sushma Sabe Madam, who is Professor TNMC and BYL Nair Hospital, Mumbai, and she is also our zonal member of Women's Committee from Mumbai, to give the vote of thanks.
Thank you so much, ma'am, and thank you, MahaAP, for giving this opportunity. I wish to extend our thanks to Dr. Hemant Gangolia, our dynamic president of MahaAP, and as well as a dynamic secretary, Dr. Amol Pawar. We have with us Dr. Jay Bhandarkar, who's our state convener. Big thank you to sir. We thank all our esteemed judges for today, that is Dr. Shishir Modak and Dr. Prakash Vaidya sir, for their guidance. And of course, our mentor sir, our own Subbu sir, we totally agree with you that though you have given us a simple messages, but they really meant a lot, and we have really learned the sideways and the highway. That was a new concept I personally learned today. So thank you so much for that, sir. We thank all the speakers who have done an excellent job and given us such a lovely scientific quiz today. And we thank you all our digital team, that is Pallavi Madam, Dr. Neha Singh Madam, and Dr. Vishal Raut. And not but the least, our delegates, which without them, the seminars are just not of any value, and they every time encourages us to conduct such webinars. Thank you so much. Thank you, everyone. With this, shall we conclude our session?
Yeah, sure. And also we'll be meeting next 19th July at the same time, 9 p.m. on the 3rd Tuesday of July for the next session. Just a reminder. Yeah.
Thank you, everyone, once again.
Yeah, thank you all.
Good night.
Thank you, ma'am.
Tomorrow is there another session, decoding vitamin D by Dr. Ganesh Javlikar.
Okay.
Thank you.
And also thanks to Dr. Sonali Shirbhate madam, who is the co-convener of this women's committee. Along with that, I also thank Dr. Sushma Pallavi